Thank you for the invitation. It's always a challenge being a radiologist to be in front of all of you as hepatologists and gastroenterologists. The intention of my talk, there is some overlap with your talk, of course, the previous talk, because you have been talking quite a lot about imaging. But this is good in order to reinforce our knowledge in these lesions. So my intention will be to show how we as radiologists see these lesions and if we can differentiate between the most common benign nodules and HCC mainly. So I have divided the agenda, and I will speak about very briefly about physiopathology, but talking about imaging, what's the image part of physiopathology. Most of my topic will be about Budd-Chiari and a bit about Fontan. So the main driver of the nodules that do appear in these livers is a lack of portal inflow. And there are some other drivers for the appearance of tumors as necrosis, oxidative stress that trigger genetic mutations. But the main reason to have these hypervascular lesions will be the lack of a good inflow from the portal. So what happens if the portal decreases, the portal flow decreases? The total flow in the region has to remain constant. So the arterial inflow increases. And this is what we call hepatic arterial buffer response. So the images I'm showing you, this is a normal patient, a normal liver, a 36 years old lady, and this is an FNH. This is a normal FNH, and it's quite similar what we see in our patients. So we see a very hypervascular liver lesion, nearly isodense or isointense in the rest of the faces. And what we see is as a response to a vascular abnormality, hyperplastic and regenerative response. And this is what we see in our patients, actually. That's why the nodules pathologically are exactly the same. So let's see what happens in Budd-Chiari syndrome. So regenerative nodules developed, and actually they are quite frequent, up to 50% of the patients. Usually they are numerous, and they have variable size. We see also adenomas, and of course HCC, which we will speak later on. So this is the typical case, one of our patients, 22 years old. You see this hepatomegaly, dysmorphic liver with innumerable lesions that enhance in the arterial phase, and in this particular case, they are iso or retain contrast in the portal venous or delayed phase. This is not a problem. This is what we expect to see, and we are not worried about these nodules. Below, you see the same patient in MRI. Again, hyperenhancing in the arterial phase. Some of them may have a central scar. This is not very common, but we can see that. See this other case, a male 29 years old. So again, we see innumerable arterial enhancing nodules. But what happens in the portal venous phase? One of the lesions is washing out. This is not common for FNH. And these lesions we are saying that are like normal FNH. But this is not common. Another patient, 41 years old. This patient in particular had a TIPS, as you see there. There are several nodules, different sizes, and a couple of them are washing out. So you all know, you deal with liver diseases and with HCC, that the keystone on HCC precisely is hyperenhancing in the arterial phase and washing out. So are these lesions I showed you before HCCs? Because this is what we deal with. This is the typical table we use as radiologists, and is based in LIRADS. And LIRADS always deals with hyperenhancing lesions in the arterial phase, and the main feature is washout. There are two other features, a capsule, enhancing capsule, and the growth in time. But mainly is washout. But be careful, because it's very clear, and still I see reports and I see papers that they report their cases LIRADS 4, LIRADS 5. That's wrong. Because LIRADS does not apply in cases of cirrhosis due to vascular disorders, irrespective if it is Budd-Chiari, congestive liver, from Fontan, or any other lesion. So LIRADS does not apply in these patients. Let's see this very nice study in which we will see how frequent are these nodules that wash out. So this study from the group in Clichy, in Paris, in France, they tried to see which is the specificity to diagnose HCC in patients that wash out in Budd-Chiari. So you see that up to 30% of the benign lesions will wash out. And as we have many more benign lesions than malignant lesions, it turns out that 83% of the lesions that wash out and are hyperenhancing in the arterial phase are benign lesions. So we cannot rely in these patients in hyperenhancement in the arterial phase and wash out to tell them HCC. That's not true. That's why LIRAS does not apply in these patients. So we don't have pathognomonic features, but there are some characteristics that can help us. See, for example, this patient, Budd-Chiari. We see that there is a hyperenhancing nodule in the arterial phase that is washing out. But we have some other feature, which is hypointensity in this case in the pre-contrast T1. And it doesn't matter if it's in CT. In CT would be hypodense. We know that in these cases, so hyperenhancing in the arterial phase, washing out, and hypointense or hypodense in T1, the specificity for HCC is 100% in this paper. So that's very important. There is another feature which is clinical. Hyperenhancing in the arterial phase, washing out, and alpha fetoprotein more than 15 nanogram per milliliter, that's 95% specific for HCC. Of course, we have to consider the regular features we always see. For example, see this patient. This is a female, one of our patients, 35 years old, and in 6 months, we see how large this nodule has grown. This is absolutely atypical. We did a biopsy, and of course, there was an hepatocellular carcinoma. By the way, most of these hepatocellular carcinomas will be low grade. What about this case? Another case from our files. Female, 35 years old with Budd-Chiari. You see all this collateral circulation in the abdominal wall, and we see a hyperenhancing nodule in the arterial phase, washes out. See the coronal. There is a specific feature which is abnormal, which is a pseudocapsule, enhancing pseudocapsule. That does not happen in benign nodules. And apart from that, this patient had an alpha fetoprotein of 41, which is completely abnormal. A biopsy was done for this patient and it was an HCC. So the incidence is variable between series, but usually an annual incidence up to 2.8% with a cumulative risk at 5 years of 18.5%. This is variable again, depends in Japan, the incidence is higher, depends on the primary etiology, but I mean, there are quite a lot of patients that could develop HCC. So what else? What else we can do? So we have some not normal contrast. We have what we call hepatospecific contrast. So how does it work? We inject the contrast, and this contrast is uptaken by membrane transporters into the hepatocyte, and is kept there. And that's why we see these lesions iso or hyperenhancing with hepatospecific contrast. As this case, this is again a normal FNH. Normal FNH means normal hepatocytes. It's hyperenhancing in the arterial phase, and with hepatospecific contrast, it will uptake because these are normal hepatocytes again. You see here the FNH. And later on, this contrast is secreted through the bile duct. However, if we don't have normal hepatocytes, there won't be uptake. So whenever we use hepatospecific contrast and is hypointense, it means there are no normal hepatocytes. And that's very worrisome. These patients should be biopsied. See this nice paper also. So in this paper, they gave hepatospecific contrast. And it happens that all benign lesions were iso or hyperintense. So they had normal hepatocytes. That's very good because it's very specific to rule in benign lesions. And all the hepatocellular carcinomas were hypointense in the hepatospecific phase. So see in the upper row of the images how this hyperenhancing nodule is retaining contrast, again meaning normal hepatocytes. This is a regenerative nodule. What about this other lesion? You see in the hepatospecific phase, it is hypointense, has no normal hepatocytes. Even more, we discussed this previously. In the T1 pre-contrast, it was hypodense, again, very worrisome. It was biopsied, and this was an HCC. Let's talk very briefly about Fontan disease. I'm not going to talk because I don't want to have an overlap with the previous amazing speaker, but you know that vast majority of these nodules, again, are going to go to be FNH-like. So the pathophysiology is the same at Budd-Chiari. Don't expect anything different. So see, this is one of our patients, male, 35 years old, Fontan done 29 years ago. So as you see in the T2 and T1 pre-contrast, nothing is seen, which is quite common, by the way, in this kind of patients. There are mild difference between Budd-Chiari and Fontan. In Fontan, most of these nodules are not seen in T2 or T1 pre-contrast. In the arterial phase, however, we see nicely a hyperenhancing lesion that is washing out. So what's this? Is this an HCC? Is this regenerative nodule? Let's see. So what will we do then? What should we do? Hepatospecific contrast, right? So this is this same patient with hepatospecific contrast. What do we see? This lesion is retaining contrast, meaning normal hepatocytes. This is a regenerative nodule. And we are confident, we are very confident about this. We can confidently say that. This is the incidence, as the previous speaker has highlighted. In the first 10 years, we don't expect to see HCCs. It has been described very, very, very rarely, so I don't expect to do follow-ups for these patients before 10 years after the Fontan procedure. However, of course, you all know that the incidence increases if cirrhosis is present in these patients. So this is what we don't want to see, right? This is a patient that had a Fontan 32 years ago, and when it came to our hospital, when we saw these patients, we saw these images. What are we seeing here? A very large, hyperenhancing, very heterogeneous lobulated lesion. These are not the images I showed you before. It's washing out in the portal venous phase. This is the typical morphological changes of Fontan. This is the same patient. Look how he has innumerable lesions, and this very worrisome lesion in the right lobe. Even more, if you see carefully in the right part of the image, there is tumor in vein. Of course, this never ever happens in a benign lesion. So this is a very unfortunate case of HCC with tumor in vein. The patient passed away months after this diagnosis, unfortunately. So let's recap. So the main driver for most of these lesions is a decrease in portal flow. Then we have a buffer arterial response. And then the most common lesions are FNH-like and HCC. Yes, there are adenomas, very rare. There are some other lesions, very rare. These are the most common lesions. So the problem comes with these lesions. A percentage of them, they wash out. And that's a problem because then we have to put the differential with HCC. How do we deal with them? CT or MRI? Probably it's better to do MRI. Most of these patients are very young. Ultrasound, I think, has many problems. We can discuss about that later in the discussion, if you will. And we can use other contrasts and, of course, alpha-fetoprotein. And doing so, we would be able to differentiate many times between FNH-like nodules and HCC. So which are the take-home messages? So we know that these lesions are very frequent. Remember, up to 50% of the patients, it doesn't matter if Budd-Chiari or Fontan. Most of the lesions are going to be FNH-like, and the problem is the differentiation with HCC. The rest of the lesions are there, but are very infrequent. So which are the red flags? We have to think about the normal issues we see. So size, change in size, hypointensity in T1, very important, pseudocapsule, enhancing capsule, tumor in vein, of course, and any lesion being hypointense in the hepatospecific phase, we should do a biopsy. A vast majority of them will be hepatocellular carcinoma. Of course, always correlation with alpha-fetoprotein, which we know The limit is 15 nanograms in patient with Budd-Chiari. With Fontaine, 10 is also a trigger. So MRI and imaging in general is excellent as a tool, but we need correlation with you and to be in head-to-head with a good pathologist and a hepatobiliary surgeon so that we can diagnose this patient as good as we can and give them the better treatment. Thank you very much.